Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry, and I am your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services Administration on Intellectual and Developmental Disabilities and the Florida Developmental Disabilities Council. Tonight is the fifth installment of our 12-part series, occurring every Tuesday night at 6 p.m. Eastern Time through October the 9th. Each part of the series is accredited by the American Academy of Family Physicians for 1 hour of AAFP prescribed credit. This is recognized by the AMA as equivalent to 1 hour of AMA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org, and the archives are accredited for CME credit for the next 2 years as well. At the end of the webinar tonight, we will give you more information about how to obtain your CME certificate. And for those of you who are not physicians, you may also use the link to obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar series. As always, at the end of the presentation tonight, there will be some time for questions. So if you have any questions, please type them in the question box of your control panel as you think of them. We will try to get through as many questions as possible during the time we have left. So physicians who treat patients with intellectual and developmental disabilities often rely on third-party sources for historical information about the patient and treatment planning as well. These third-party sources are referred collectively as the patient's circle of support. And accessing the circle of support is often critical to successful management of the patient's health needs. So tonight we're going to be discussing this concept in further detail. And we'll also be featuring a tool developed in Florida called My Health Passport that helps patients and their circle of support gather the information that physicians need in order to render the best care. Tonight, one of our previous speakers will be returning to discuss this tool. Her name is Dr. Liz Perkins. Dr. Perkins is a research assistant professor and health coordinator at the Florida Center for Inclusive Communities at the University of South Florida. She has a PhD in aging studies and a BA in psychology from USF. She is originally from the United Kingdom, where she is an RNMH, that is a registered nurse from the United Kingdom trained specifically in the field of intellectual and developmental disabilities. She's an expert on aging in intellectual disabilities and caregiver issues. Dr. Perkins' work has been published in a variety of journals, including the Journal of the American Medical Association, Academic Medicine, Clinical Gerontologist, and the Journal of Policy and Practice in Intellectual Disabilities. She is also currently on the Board of Directors for the American Association on Intellectual and Developmental Disabilities. Starting us off tonight, however, is Dr. Jeff Okamoto. Dr. Okamoto is the Medical Director of the Developmental Disabilities Division for the state of Hawaii. He is board certified in both pediatrics and in developmental behavioral pediatrics. He enjoys clinical work at the Kapiolani Medical Center for Women and Children and is faculty at the John A. Burns School of Medicine. Dr. Okamoto obtained his MD degree at the John A. Burns School of Medicine at the University of Hawaii at Manoa, and his residency in pediatrics was at Kaiser Permanente, Los Angeles, and his fellowship in developmental behavioral pediatrics at Children's Hospital in Los Angeles. He also obtained a certificate there from the Leadership Education in Neurodevelopmental and Related Disorders program. Dr. Okamoto was also a public policy fellow in Washington, D.C. for the Joseph P. Kennedy Jr. Foundation from July 2010 until June 2011. So I would like to now turn the presentation over to Dr. Okamoto. Dr. Okamoto, can you hear me?
Yes. Thanks for the nice introduction, Matt.
Thank you, Jeff.
So this is a talk about the support system for people with intellectual and developmental disabilities. There's several objectives. I have to say that it's really meant to be a talk to get everybody up to speed. Some of you actually may be very familiar about accessing your support systems in the community. some of you may just be starting in terms of your work in that. And so my hope is that we can get everybody up to a certain level and then take some of the more experienced people to an even higher level and hopefully give everyone something to take home in terms of strategies for supporting folks with intellectual and developmental disabilities better. So the objectives include learning a little bit about the concept of circle of support, and it's really something that's quite popular and well used by many folks. So we'll go over that concept. A very important thing is to realize some of you are not physicians out there, but people who are physicians certainly need to use other team members, and those team members can be critical in terms of really well supporting someone with a disability. There is actually quite a bit in the patient's own support system that might be able to be answers to some of your health and well-being issues. So we're going to talk about how to tap into that support system that the patient has. But there are some resources that the patient may not be connected to that you might want to use. And so understanding some of your local resources are really quite important. And we'll talk a little bit about some of the Florida resources, but certainly a lot of the resources you can tap into are available in most states. So we'll look at some of the resources that you know, might be quite important for the person that you're particularly taking care of. It's all going to lead to actually being able to use a patient support system and a circle support in terms of preventing high-risk situations and also dealing with high-risk situations. And unfortunately, people with intellectual and developmental disabilities often are jeopardized in safety and not getting care. So we'll certainly touch on that. And there's also issues in terms of the person at home being possibly exploited, either financially or in terms of sexual or physical abuse. So we'll certainly link how to prevent high-risk situations and vulnerable situations from happening by using your circle of support and your outside resources. So for the physicians out there, we're certainly actually part of a team. And in as much as I think we have very important roles in terms of diagnosis, evaluating patients, doing the right kind of treatments, and making referrals, we really are actually able to be even more effective if we're linked to community supports and also use people that have other skill sets in the patient circle. So some of the things that you could enable actually is to ensure that somebody's safe. And we'll certainly have some case scenarios in today's presentation to sort of look over those kinds of safety issues and how, you know, as a physician, you actually may very well be ensuring that the safety is happening by linking the patient to correct supports. And then we also want to optimize functioning. So about a third of this presentation, we'll be talking about functioning, and certainly health is a big part of functioning, but there's a lot of pieces to that, and we'll go over some of the more important functional issues for people with intellectual and developmental disabilities. So really, you can expand your effectiveness by allying with people around the person with intellectual and developmental disabilities. If you can connect your patient with these other effective people, sometimes they actually are doing even more important work than the work that you're doing. You know, you're certainly taking care of some health issues, but if a person, say, has a vision issue and they do not have that vision issue taken care of, they really have a much poor quality of life. So if you can attach your patient to a person who can address the vision issue or other issues such as rehabilitation or housing or employment, you really can completely revolutionize this person's functionality and what they do in their day-to-day living. You may be able to work with these other people in a couple of ways. One is just having a phone discussion. So, you might call another support person and just say, hey, I would like to connect my patient to you. Or if this person is already working with the patient, you might call them up and cooperate and collaborate. Another way to work together with other team members is to get everybody to meet in the same place. That may be actually your clinic or the hospital that you work at, but certainly meetings occur in a lot of different places. For younger children, that could be the school, but for adults, it could be a place that they do some activity. So there's a lot of ways of expanding your effectiveness by either doing phone calls or actually having physical face-to-face meeting with other team members. So here's some examples of teaming. You might actually have a woman with Rett syndrome, and you realize actually part of Rett's is that they can have some cerebral palsy type symptoms and signs such as truncal instability, and you refer the woman with the Rett syndrome to a physical therapist for the truncal instability. One of the things in Rett syndromes you often see is their constant hand-wringing, and they can really have a lot of problems functionally with their hands because they're just hand-wringing. They're not actually grasping things, and so an occupational therapist could be quite important. So for a woman with Rett, you could use a couple of different types of therapists to really start to work on the functionality. Another example is that you might actually have a person in a Medicaid waiver, and we'll go over that later in this discussion, but there's these personal assistants as part of the Medicaid waiver program that are working with a patient, and they note that he's sticking his hand in his mouth all the time, and he never used to do that. Well, that's something that you can certainly work on, but you may actually need to team with others to look into evaluating that situation and then managing that. It could be something like a toothache or an abscess, or it could be something like reflux. So, there is actually, of course, a workup that you might start thinking of, and then what team members you'll need to do that evaluation and management. Really important issue is transitioning from school. So if a child has an intellectual or a developmental disability, they may be going through school and then a child graduates. So a family may want to know, oh, what do we do now? She's stopped school. And so you'll need to think about teaming with others to have her be either employed or to have activity to do now that she's not in school. So those are all examples of ways you could team with others and problem solve around your patient. Okay, so who's part of the team? You can certainly do this in a couple of different ways. You may already just think, depending on the scenario, about a team member or a group of people that you might want to link your patient to. There are methods, though, of doing it in a fairly efficient, quick way. And one way that some professionals try to figure out, okay, who do I need on this team to problem solve an issue or to help a patient be more functional, is to use mapping. And there is a lot of different mapping systems. An example of a mapping system is the McGill Action Planning System. Acronym is MAPS, M-A-P-S. So you can Google this and have a look at it. But the McGill system is like most mapping systems. They use a number of tools to identify what the issues are for a patient, also identify some of their desires and what they're wanting, and then also have tools to identify people who can then help and solve your problems. So I think the worst thing you can do is actually use a map, find out a problem about a patient, and then not know, what do I do now? So the nice thing about mapping is that you'll not only discover the issues that you need to address, but you can also help solve it by doing the mapping. So in the McGill system, there's a circle of support map, there's a community presence map, there's a number of other maps, and a lot of them are visual. So for those of you who really like to draw or chart things out, these are really great ways of figuring out a person's situation. But we'll go over circle of supports more closely. Okay, so I have a visual, and if you wanted to visualize a circle of support, you might think the person's in the center, and some people will do sort of a ring around that, and some people will even draw other bigger rings around it, and we'll go over about what you might do to graphically show what people are in a person's circle of support. But you can use this concept for all types of patients, but certainly those with intellectual and developmental disabilities. This is a very nice concept to understand who are the people supporting the person with intellectual or developmental disabilities. It could be the person's immediate or extended family. Certainly friends can be very important. Workplace peers, so if the person is employed, you know, people who are working with the person. Professionals can be part of the circle of support, and people that they often see in the community. So for some people with IDDD, one of the most special people might be a bus driver that they see all the time. Certainly that can be part of the circle of support. What's interesting is you can also involve pets and animals in the circle of support. So even though in the slide we put people here, you can involve pets and animals in the circle of support. So let's talk about one way of thinking about circle of support. This is from Judith Snow. She talks about 4 circles of relationships. And as you can see, the first one is the very close people for this individual who they can share secrets with and have heartfelt emotions for. So that's a circle of intimacy. So very, very close people. And then you might conceptualize a little bit more outside circle of friendship, where these are friends and these are people that the person with intellectual or developmental disability goes out and does things with. And then there's another circle of people in organizations the person with IDDD might be involved with. That might be a workplace. It might be a club that the person's involved with. There's several types of organizations that the person can be involved with. So this is sort of a circle of participation. And another circle might be the circle of exchange. And these are people who are paid to be in the life of the person with IDDD. And we'll certainly want to talk a little bit more about that, because that would include a lot of the health and non-health professionals in the life of a person with IDDD. Okay, so how do you activate the circle of support? So again, you can certainly make phone calls and talk to team members through the phone. But it might be nice to actually have a sit-down where everyone that the person might be connected to, that you might want to get more information from or to be able to use as problem solvers, come and meet together. You can have family members, therapists, community members. You know, it could be somebody from some people from the person's church, could be people from the person's club, and they can talk about how the person is doing. And what's nice is you have a number of folks now that can help you solve problems. So instead of just being the sole physician trying to solve a pretty big problem, you now have a number of folks who can team together to solve problems. One of the big goals is to optimize functioning and involvement in the community. Now, you can do this as a physician or health professional, but certainly agencies and particularly people who are paid to support the person can also call a meeting of the circle of supports. And they may have non-health issues to problem solve, but they may also include health issues. So what kind of roles and responsibilities can these circle of support members take? Certainly we're talking about a lot of health issues, and so some of our scenarios will have health issues. Safety can be a major role, and there are people with intellectual and developmental disabilities that are in quite tricky situations where someone is abusing them. They are at risk for abuse for a couple of reasons, and we'll go over that in a later slide. So you'll have to think a little bit about safety often. And then there's a number of other roles that really do lead to better health and often safety if a person is well connected to their community in terms of their activities. If they have a job, all of a sudden you have a built-in safety network often because of peer relationships and also the sort of the boss-employee relationships. Transportation can be a huge responsibility, as oftentimes there's a great place for a person to participate in, but there's no way of getting there. So one of your circle of support members may have a way of getting the person either to the job or to an activity in the community that the person wants to go to. Advocacy, we'll talk a little more about that in a future slide, but advocacy is an important responsibility to ensure that the desires of a person with intellectual and developmental disabilities are taken into account, and we can advocate for the person to get their needs met. And then the last role I wanted to talk about is being able to make decisions for oneself. So oftentimes we're not as responsive, I would say, as medical professionals in terms of how to help the person make decisions for themselves and then how to express that. And you may have a number of circle of support members who can really help with that particular role. So depending on the person's level of functioning, it's going to be different if a person's mildly affected versus profoundly affected. And depending on their strengths and their issues, the roles and responsibilities of your circle is going to change. And you'll need to take into account also their dreams and their needs. But so a person with milder issues may have very different circle of support types of responsibilities than a person with more profound needs. I find in my own work that this can be very interesting working with the circle of support. You can certainly individualize support, so in as much as I might take care of 25 people with Down syndrome, they're all very different, and so you do want to individualize those supports, and the way you often do that is to understand their circle of supports, to understand some of their needs, and then to individualize their supports. It can be very challenging to work with the circle of support. I would say that there are some people who have different ideas about the individual, so you'll need to work together and collaborate to team. But the clinician is a really excellent person and is in a very good place to help and to be part of this circle of support. So I want to talk a little more about the circle of exchange, so people that are paid to be in the life of a person with IDDD. Certainly the circle of intimacy and circle of friendships are critical and important, and of course if you find that your patient are missing some of those circles, you already have a very nice issue to work on. And certainly the circle of participation is important, but let's talk a little bit about people who are paid to be in the life of a person with IDDD. So there's a lot of health professionals, and then there's non-health professionals that can have a great impact. And the way to sort of think about that is what are functions and activities that the person with IDDD should optimize. So there's often sensory and motor issues, and medical people are often clued into those very well. But there's also some others: communication, behavioral issues, housing issues, employment, and recreation issues. And oftentimes, if we can optimize some of those other functions and activities, we really help our health and safety issues. So let's look at each of these. So we already talked about a person that has a possible vision issue. So hearing and vision are huge in our society and for a person in a community. So I think most of us realize that, we would take advantage of our audiologists and hearing experts as well as our ENT folks to optimize hearing. And there's a lot of technology involved with that, up to even getting a cochlear implant to help a person who's deaf to hear again. And I think most of us understand the relationships with eye specialists. In the motor issues, having somebody be ambulatory, being able to move well, to be able to use their hands properly in terms of handwriting and grasp, and then to also decrease pain, spasticity, and deformity, we want to use our experts on motor issues. So there's a variety of people, including physicians in orthopedics and in rehab medicine, the neurosurgeons who often will put in a baclofen pump or need to give injections to help a person with spasticity. There's a number of therapists, including physical and occupational therapists. The therapists now are getting very good at assistive technology, which would include augmentative communication devices. So there's a lot of ways of using technology to now expand the functionality of a person in movement as well as in communication. And there's a number of equipment issues to think about, all of which you would need to use your circle of support to enable experts in those areas to fit the person well and to get the right equipment. Okay, communication is a huge issue, and I think we already had a nice telecast about a webinar about communication and how to communicate with folks with IDDD, but we want to optimize this as much as possible. The more they can communicate their needs, wants, and issues, the better we can do our job. And certainly the speech and language pathologists, again, the assistive technology experts and augmentative communication people can help. There's a number of equipment in this area also, and I think what's often revolutionizing a number of our folks are the use of iPads, and there's a lot of applications on these iPads now that families are taking advantage of and the experts are getting very good at using. Okay, the next slide is about behavior, and we realize that there's a number of behavioral experts, including psychologists and psychiatrists. They can be very helpful in terms of decreasing undesired behavior, increasing proper behavior, and also decreasing unnecessary medication or physical restraints. So yeah, that's another very important area of professionals that you want to take advantage of. Okay, now some things that some medical professionals don't often think of would include things like housing. And when you think about it, though, it can greatly impact health. If you're homeless, that's going to be a totally higher risk situation than if you're living in a comfortable and safe situation. And with people with intellectual and developmental disabilities, it's really important to think of how much supervision does a person need. And we talked about in a previous slide about having them have a voice and to have self-determination. But we realize that some people really need some support to make sure that they're safe and healthy. If they're in their own home and they're independent, that's great. That's really, I think, our goal for people with intellectual and developmental disabilities. But then some people may need more supports. They often live with their parents. They may live with other family members. Sometimes the parents are aging out or the family members are not able to take care of a person, so they'll need to be placed in other settings such as foster homes, intermediate care facilities for mentally retarded. They'll probably rename that to ICFID soon to reflect the intellectual disability terminology, but those are group settings that are residences. Some people really need a nursing home, and then there are some people who are in an institution, and we still have a number of those across the United States. I want to elaborate a little bit about living space as it's so critical for a person's health and safety. So there is a shift away from institutions. There are several problems, and probably the impetus for moving away from institutions. There were high levels of restraint and abuse in these institutions. Oftentimes they may have been funded really well at the beginning, but then as they lost funding and people started to neglect the funding of institutions, they would lead to overcrowding and then abuse. They often are isolated from their families and communities because they're in the institution and not in their own home or community. And they can actually be quite expensive. The advantages, though, of institutions is you can concentrate resources and expertise. You can have on-site care, including medical and dental and nursing and rehabilitative care. So you really could have a concentration of care at the institution. The teams can be formed more easily. But we would have to say that most of these advantages can occur in the community and the problems of the institutions avoided. So there is a movement away from institutions. The Supreme Court had an Olmstead decision, and the decision really showed that individuals have a right to community integration under the Americans with Disabilities Act, and that if we segregate those with disabilities, including putting them into institutions, that constitutes discrimination. So over the last few years, the Department of Justice federally has filed briefs or joined lawsuits to enforce the integration of people with disabilities, including those with intellectual and developmental disabilities. The lawsuits have included states with the largest number of people in state institutions, including Florida, Illinois, and New York. There are now several states without a state-run institution, so here's a list of them, and Hawaii is one of them. So we've not had an institution since 1995 and have had everyone in the community. Now, people with intellectual and developmental disabilities used to have their circle of support be the institution. So then who is in the circle of support when there is no institution? Well, we talked about that already in terms of the several circles of support you might consider, including family members and friends. But there is now a Medicaid waiver for people with intellectual and developmental disabilities. And what that is actually, it's often called the Beckett waiver. Beckett was in an institution, which was a hospital, because of her many needs. And the mother complained, why can't I have her be at home? And Medicaid said that they could only pay for Katie's care in the hospital. There was no such thing as a waiver previously to put somebody in the community. But now, because of Katie Beckett's family's work and federal government, there is a way for Medicaid to pay for services in the community that used to just be in the institution or hospital. There's a federal match, so the state puts in money and then the federal government matches. Some states will use 100% state fund for services outside of the waiver, but most states will get that match. Okay, so if you're not in an institution, the circle of exchange can include waiver services. And it's a very nice thing if you're the person that you're working with an intellectual or developmental disability has waiver, you can reach out and get a lot of information from people who are waiver providers, and then you can help solve problems with the waiver services. So in Florida, there are a number of services that people with intellectual and developmental disabilities can get. You can see the array of different kinds of behavioral services, therapists. On the right side here, you can see there's equipment and supplies you can get, respite care, which is to give the family or people who are taking care of the person, give them a rest from taking care of a person. So there's a number of nice services and obviously solutions to people with intellectual and developmental disabilities in terms of their issues and problems. So Florida has a rich array of waiver services. This is an area that's also changing quite a bit. So just like housing, where now we have a lot of deinstitutionalization, there is now a revolution in employment for people with intellectual and developmental disabilities. When they're in school, certainly there's special education law, and then there's vocational rehabilitation services. But once they're out of school, there continue to be ways of training a person and getting a person to have opportunities for employment. So these include vocational rehabilitation services. The waiver services can help with employment, training, and then nonprofits in the community can help with supporting a person once they're out of school. We talked about transportation already, so it's very nice. Like the Florida waiver has transportation. If you can get a person to the activity that they want to do post-school or into employment, that's very helpful. Here's a function that we often don't think of in the medical world, which is recreation. But it can certainly help a person have a lot more self-esteem and to have a lot more happiness with the quality of their life by being connected to recreation. Special Olympics is a very great support for certain people. The Special Olympics, of course, have quite a bit of support for various kinds of disabilities and understand the issues of the disabilities to enable a person to participate. There's camps for all number types of disabilities, and certainly family events can be a good recreational activity. Issues include access again and transportation to and from. So in Hawaii we have beaches, and it's nice if a person in a wheelchair has a ramp that goes down the beach so that they can get to the water. Otherwise their wheelchair might get stuck in the sand. So there's issues of access that sometimes need to be problem solved. Now oftentimes a person that is supporting the recreational area can relate a different side of a person with IDDD. You might hear a little bit different story about how functional they are in their recreational activity. So that's a nice other piece in terms of more information about a person with IDDD. Okay, there's a lot of both national and state resources. Some of the prominent ones include Easter Seals, the United Cerebral Palsy Program, the ARC, or the March of Dimes. But that's just a short listing of so many resources that you might be able to tap into to help you with your circle of support and to increase the team members that are helping the person that you're taking care of with IDDD. And then there's a number of groups like sibling groups where it's not necessarily just the person with IDDD, but the sibling of a person with IDDD that you're supporting. There's camps, arts and crafts, family training, so there's a lot of different resources that might be available to help your person with IDDD and their family members. Okay, so I think we'll go on to some scenarios. So we'll practice some of these principles. So when we're looking at these scenarios, remember functionality. So we're going to be thinking about increasing functionality in several areas. We want to decrease morbidity and mortality, of course. We want to utilize the circle of support to solve problems. So the circle of support can help you identify resources. We can figure out what roles and responsibilities people might take, and then we do need to coordinate the circle to enable solutions. And then there's a number of roles and responsibilities that circle of support members can take. Our big area often is health and safety, but also we can look into expanding it into community activities, employment, transportation, advocacy, and then trying to help a person make decisions for oneself. Okay, so let's look at this first case scenario. This is a 30-year-old man named Andy, and Andy has profound intellectual disability and unfortunately is nonverbal, and he's found to have an abdominal mass, so he's admitted to the hospital for an evaluation for that, but the hospitalist does not want to do any tests. He sees Andy and he just feels that, number one, Andy's not going to understand any test that we do, and that Andy will become agitated. So let's think about that scenario a little bit, and who should be involved? Who more can give more information about Andy's situation, and what roles should the circle play? So this is Andy. He has an abdominal mass. We want to know a little more about the abdominal mass, but the hospitalist does not want to work with Andy because of several fears. So thinking about who might be involved, you might think, geez, well, if Andy's nonverbal and he's profoundly affected, who is his family? Well, it happens that Andy has a guardian. His family's not involved anymore, but there's a guardian who makes decision for Andy. And so contacting Andy's guardian, you find out that Andy is connected to the Waiver Services, and there's personal assistance as part of the waiver. And the personal assistant, Andy actually has one particular one that he really likes and really trusts. This personal assistant says that, well, there's been some behavioral services because Andy's had tantrums in the past, so the hospitalist has maybe some reasons to be worried about Andy becoming upset or not wanting to have certain types of evaluations. But the behavioral services found out that Andy calms himself by flipping through a telephone book. So if you can give Andy a telephone book, he's calmed down quite a bit. The other thing that people have found out that he really likes ice cream. So Andy really likes ice cream. So taking into account some information that you found out from the guardian and then from personal assistant, all of which certainly can be considered circle of support for Andy, you might start to come up with some answers on how we might get some evaluations done for this abdominal mass that Andy has. We can certainly help with the procedures by having him have access to the telephone book, something you may not have known about without asking the right person some questions about that. We can reward Andy with ice cream. And certainly the personal assistant might be a person that we might want to have through some of the hospital evaluations or the outpatient evaluations that we do for Andy. So already we have some nice problem solving going on just using the circle of support for Andy. Now, as you can imagine, Andy not getting any evaluations for the abdominal mass puts him into some danger. He might have cancer, or he might have something that could be treated in terms of the abdominal mass, but if we don't ever look into it, he really is in a high-risk situation. And it can occur in multiple places within the healthcare system. Part of some of the issues include not getting appropriate care, just like in Andy's case. There might be wrong patient identification, and a person may not be able to speak out for themselves that they're not the patient that the staff thinks the person is. As we know, even with people without IDDD, you might be working on the wrong part of the patient. And then there's hospital-borne infections. So all of these issues that are applied to all patients can be exacerbated in a person with IDDD because of their communication issues and stigma issues. Communication, therefore, is key, and so we really want to improve the functionality of people's communication as much as possible. But certainly some of our folks, even with the best of training, have poor or no communication skills. They may have unusual behaviors that are mistaken for aggression, or they may actually have aggression. There may be a number of behaviors that frighten medical staff, so staff's sort of less wanting to work with the person. There's a lot of comorbidities that the team may not recognize. Vision issues. One of my patients has a diabetes insipidus, and so if you're not recognizing that he has that problem, you may provide the wrong care. There may be very complex needs in this population. One of the most important things I would say is that the attitude of the professional. So the hospitalist may have had some issues in terms of Andy's behavior, but part of it is an attitudinal issue that they may not want to do testing on a person with ID, feeling that that's not as important as giving care to a person without ID. Sometimes there's poor clarity on who is making decisions. So there's one solution for people with IDDD in healthcare situations called a health passport. So I'll have Liz describe that, and I think you'll find it to be a very helpful support.
Thank you, Jeff, and thank you for the wealth of information you've shared thus far with the audience today. It is my pleasure to be here just to talk very briefly about My Health Passport, which is something we developed here at the Florida Center for Inclusive Communities, along with our Community Advisory Committee, when it was judged that it was an important thing to be able to give good information to healthcare providers. And particularly the Health Passport was designed specifically for when individuals have need for hospital or clinic treatment and they're in an environment where the health professionals are unfamiliar with them. And with that being said, it needed to sort of serve the purpose of being something that was eye-catching, that was going to give very good information, but was not a piece of a document that was going to be overlooked or by somebody, one of the caregivers and the individuals, for them to be able to fill this information out and to be able to really personalize so the information that's given and that's shared to healthcare professionals, really with the goal of increasing the chances of modifying the environment and making staff aware of what could really be very, very helpful in these situations. And so, you know, when you look at what was out there in terms of health passports, they can be very in-depth. They can be, you know, and give a lot of information. So you do have to have a balance between what is going to be very useful, very effective, and it's going to be utilized and it's going to be noticed by staff. You know, if you go in with reams and reams of information, chances are that it will overwhelm staff and it won't be utilized. And so that was sort of the balancing act with designing something that was eye-catching, that would be grab the attention, and also to give that useful information. And Jeff just mentioned a good example about an individual that has a situation where if he gets agitated, you know, being able to look and tear a telephone book is a way of calming him down. You know, information like that is not something you would know from medical school. It's knowing about the individual, and a lot of this information is from when you know an individual well and you work with an individual and you have the information that's given from caregivers, it's given from family members. And so it's really a two-way document. You know, the individual, family have this information, and it's going to be beneficial for them to impart that information to healthcare providers. We were very careful to make the information and also the images age appropriate for any individual. And so, you know, we know that younger children have used the health passport. We know that older adults with intellectual developmental disability have used this because it's not designed just for one specific population or age group. And really the whole purpose was to make that unfamiliar become familiar. And the good thing is it's free and it's freely available, and I'll talk a little bit about how you can get a hold of those in a little while. Next slide, Jeff, please. And so what you'll notice immediately on the front cover of the Health Passport, and something that we really want to emphasize, is how does the person communicate? You know, that's first and foremost the most fundamental question that we as healthcare providers want to know. What's the best way to communicate with an individual? And, you know, this basically gives you the shortcut of what can be very useful information. And also for the individual to have a picture on this health passport. You might be encountering the individual when they're feeling very, very ill and might not look very, very different to how they're presenting. You know, particularly in an emergency situation, you might have somebody present with a health passport in an emergency room setting. So, you know, it's really good to have a sort of a standard to compare to of how a person looks when they're feeling healthy and they're feeling well. And so, you know, that we talked, Jeff mentioned a little bit about, you know, the assistive technologies and use of iPads, how a person communicates. Some very interesting information can be imparted with very little space, and that's really why it's crucial, first and foremost, fundamentally, that we look at how we can best communicate with the individual, how we can best help them understand, and how we can best have information from them as far as possible. Next slide, please. So this is a 4-page document of My Health Passport. Next slide, please, Jeff.
Let's see. There we go.
Thank you. It is a 4-page document. Like I said, we tried to keep it brief. The next page goes about the information that you sort of would expect to see: brief history, medications, allergies. But what I really want to point out on this particular page is how a person might express that they're in pain, and how, if they get upset or distressed, what's the best way you can help them by. And again, that's information, it's behavioral information that can be very important in a clinical setting, in a healthcare setting, in an environment when it is new. Things are, you've got different sights, sounds, odors, experiences that are occurring for an individual with intellectual developmental disability that might they might respond by getting distressed, and saying how they express pain, how they express when they're agitated or upset, and what's the best way that you might be able to allay their fears. So very important that we sort of, again, make a note of how that characterization for that individual might occur. Next slide, please, Jeff. The next page, I think, is a really important subject at the very top there, is how does the person cope with medical procedures? It's very useful information to sort of know if has this individual had an X-ray in the recent past. How did they react to that? How did they react to an X-ray? So as far as the wealth of information that might be shared there, that could be very useful. Whether we're very quick to impart if we like or dislike injections. It's very useful information to have that for a healthcare provider. And these other issues here: mobility, personal care needs, eating and drinking. Yes, this is information that, you know, we can, especially if an individual has this need of inpatient care for a few days, needs a surgery and things of that information. Sometimes when you have an individual with a disability, they have their own ways of doing things that need different types of assistance. Or it might be that they can manage to do certain things where it would be dangerous really for the health professional to try and interject and help with them. So it's always good to know what their abilities are and how you can best provide support for that individual when doing the activities of daily living, the mobility needs, getting washed and dressed and things of that nature. The next slide, please, Jeff. And so on the final slide, again, this is really important when you have individuals that might have certain and very strong food preferences and likes and dislikes. Individuals with intellectual disabilities, individuals with autism spectrum disorders, for instance, might have very different types of taste in terms of what they really will refuse to eat. And you know, if you're in a situation where there's a certain restricted menu, as it might be occurring in a hospital, it's good to know about those types of things, you know, and obviously help and assist with the caregiver to make that happen in terms of what's going to be beneficial for the individual. No good keep offering food that they will never ever eat and things of that nature. Also, sensitivities. You know, you think again of clinical environments. There might be places that really are quite difficult for individuals that have hypersensitivities to different odors, different the fluorescent lighting, the sights and sounds that you might have in a hospital environment might be quite disturbing. And again, it's good to know in advance what those triggers might be for reactions to those types of sensitivities. By the same token, an individual, we like to know what help pass the time and to have an individual that might be hyperactive, or it might be that they have attention difficulties with attention. So having a number of different activities that they can participate in the sort of the clinical setting to help that situation might obviously be very useful. And following up appointments, you know, some individuals cope very well in waiting room situations, some do not, and so it might be very good if you can take account for those types of things, having future follow-up appointments at a time that when there might be less people in the waiting room, to have what we call these social scripts, and to sort of have how an individual might visit a situation like this, or before it might occur, if it's going to be something that might occur on a regular basis, if somebody has need for some repeated treatment. It's good to sort of get them acquainted with the place and you know, and the staff that they're going to be interacting with on a regular basis. And so this is, let's say, it's a very simple, brief document, but can give quite a lot of profound information that can be very helpful for helping care professionals that interact with an individual in a hospital or clinic setting when they have need for treatment in such a situation. Next slide, please. And I think, you know, sometimes when you produce something that's sort of effective, but you know, very easy to implement, very easy to share with other family members, very easy to share with other professionals. Sort of the figures have sort of really quite surprised us how popular the health passport has become. It's been released for about 15 months now, and we're sort of up to about the 13,000 mark in terms of downloads that have occurred. And I also have a stash of printed copies. I don't have that many left anymore, but if you want to have some, I can certainly share, you know, sort of first come, first served basis. and also you can freely photocopy them. So the requests have come from all over, really, in terms of the utility of My Passport, My Health Passport. And what's really quite heartening is the local St. Joseph's Hospital in Tampa have been utilizing this in their triage when they identify a child with special needs going into the hospital, that this is part of their admission process now, that they fill out this My Health Passport. It becomes part of their record, and it is something that they've distributed to over 500 patients to our knowledge since it's been implemented in that particular hospital. So the whole thing about My Health Passport, next slide please, Jeff, is that I think what's captured folks' attention is that it is appropriate for different ages. It is relevant to a wide range of healthcare settings. And also, I've heard from various agencies and individuals and practitioners that have actually used it for alternative uses, as well as, you know, the intended use of supporting an individual if they have need for hospital treatment. And these alternative uses are for emergency or disaster management preparedness, as quick cheat sheets. Well, we're in Florida here, so we know about, you know, the hurricanes and things of that nature that might occur, and where you have special needs, such shelters. Something like the My Health Passport is a very quick and easy information sheet that can be very useful for staff to provide support for individuals when they are having an emergency situation. And also we've heard that it's being used as sort of an orientation for new staff members in residential settings, and for respite care providers, again, because the information, it sort of cuts to the quick of what's really important to best support this individual. And of course, the format, obviously, it can be adapted to suit different agencies. And so we do know that it's something that we hope that if you would like to utilize. Next slide, please, Jess. That you can download it freely. There's a English version, and there is also a Spanish version. And that's the website. We've literally just gone live with a new website for the Florida Center for Inclusive Communities as of this morning, I think. And so that is the website for the health section. And if you tab to under materials and resources, you can actually download or save the file directly from FCIC's website. If you have any difficulty with that, please feel free to email me at the address there. And also, if you would like, like I say, I do have a limited supply of the nice, very full color, glossy 4-page version of this My Health Passport in both the English and the Spanish versions, if you'd like some to utilize in your work settings and to distribute to individuals that you think might benefit. So I thank Jeff for allowing me to talk a little bit about this My Health Passport and its utility, and hopefully it'd be something that you might consider using. It is a tool, and one of the things that I just wanted to point out is that we do have you know, with the Affordable Care Act and the sort of the switch to electronic records, even with such information like that, this is information that's unlikely to be imparted in those types of electronic documentation and electronic record keeping. I think it's always going to be some use for something like this to give immediate information, and that can be very helpful and very useful. So thank you, Jeff, for allowing me to talk a little bit about that, and I'll hand back over to you for the remainder of the webinar today.
Thanks, Liz. That's a lovely tool and certainly a good example of how we would want to use information to better our care for people. Let's see. So the last scenario The second scenario is a 22-year-old woman, Charlotte, who has Down syndrome and PDD, which is an autism spectrum disorder. And during a hospitalization for pneumonia, she relates to a nurse that the mother is abusing her at home. So it might be something that happens in your hospital setting. A patient complains. For me, using my circle of support, I would make use of my hospital social worker, and that hospital social worker finds out that the abuse is that Charlotte's mother is not allowing Charlotte to get on the computer to search the web. And what happens is that Charlotte actually gets on the web and buys exercise equipment using her mom's credit card. So the mom's like angry about Charlotte using the credit card, and so is not giving Charlotte computer privileges, and Charlotte considers that abuse. So of course, having your circle of support help you figure out the situation better can allow you to problem solve the issue. What's interesting is that for Charlotte and one of the personal assistants that actually takes care of her at home actually complains about Charlotte's coughing after meals. So her hospitalization for pneumonia is actually possibly secondary to some swallowing issues. And so in the hospital, you might be spurred on then to do more studies and find out she actually has velopharyngeal incompetence, probably secondary to her Down syndrome, causing her to aspirate. So again, an example of how your additional extended team can help you with problem solving an issue for a person with IDDD. So to summarize, you can certainly prevent and mitigate high-risk situations that can happen both in the hospital but also at home and in the community. They may not be able to communicate what's going on, so you'll need to use your circle of support to find out more information and also to create a safety net around the person with IDDD. So, use tools such as the Health Passport to get to know who the circle of support is and also to get more information about a person with IDDD. You really want to be able to use medical and non-medical professionals. They're critical often to solving problems and also to prevent problems in different environments where your patient lives. And then certainly using a team of people expands your effectiveness and really allows you to do your job much better. Okay, Matt, we'll go ahead and put our contact information on.
All right. Thanks, Jeff. I have a couple of questions. I think we've got just a little bit of time, so we just have a time for just a couple. But I had a couple that were kind of along this line. This one says, I have a fairly busy practice and insurance doesn't reimburse me for working on a quote-unquote team. How do I get time to do this?
Well, being able to do some work in your clinic in terms of using time as your charge, so you can bill on complexity, but you can also bill on time. So say you're working with a patient and you're using more than half the time in terms of talking with the patient's support system and with other professionals, you can certainly bill for that. So I think physicians and other clinicians need to be really sophisticated in terms of using that way of being reimbursed to get some reimbursement for doing that teamwork, either on the phone or in person.
I just saw an article recently. I think that it was just forwarded to me just a couple of days ago, actually, about how CPT codes for, I think, 2013 are going to include care coordination.
Yes.
And I'm wondering if they're doing that, is that something that we might be able to tap into also?
That's right.
Yeah. So that's a good
there's
change.
Actually quite a number of CPT codes. The more sophisticated you are with them, you can certainly get reimbursed for your energy and time working around teams and also getting more information about a person.
That's great. Another question, this is about the effect of deinstitutionalization. Jeff, you're in a state that doesn't have institutions now, and I'm not sure if you were in the field or when they closed, but I'm wondering if what the effect was, and I guess that this was kind of the question was on the patient's circle of support for the people in Hawaii. When the institutions closed, how did that affect their circle of support? Did you see that expand, contract? How did the community react? What kind of frame that in the Hawaiian experience there with
yeah, actually I was a part of that, and there were a number of outcomes. Number one, there were a number of very multi-medicated people with polypharmacy that was taking off a lot of medication. The community folks decided, let's try them off of the Haldol or whatever, psychotropic they're on, and a number of them did quite well without the, large number of medications they were on while in the institution. I would say that a number of people in the institution are continuing to be very problematic behaviorally. So there is a lot of waiver services that are used to ensure that there's enough behavioral support, personal assistance, and people who are one-on-one with the individual to help them with their behavior. And so those are some of the higher cost individuals under the waiver program. Some of them are in the hundreds of thousands in terms of budget. But when you look at the budget overall with all of the folks that were deinstitutionalized, it is much cheaper to have them as a group in the community, because a number of them really are not using too much budget and actually are very functional and integrated within their communities, and they don't require much budget. But there are a number of people in the institution that require large budgets.
I have a question for Dr. Perkins about the health passport. It's a two-parter. One is there an electronic version of this that doctors could access? I guess what they're asking is could it be stored? Is this information available? Could it be stored online, and so that different doctors could access it?
I don't have that capability for this at the moment. The health passport, in terms of being available online, it is in a format that's called a typable PDF. So an individual can type the information before they print it off and have that information like that. And then you can actually have shared the PDF. So I'm thinking, an individual might be able to open it up on an iPad if they filled it out that way. We're looking into it because it is a little bit of a difficulty with having typable PDFs that save the information for some unknown reason, but it is something that I would be looking at. And at the moment, this is more of a paper type of transaction, paper document that people can utilize. The second part was, Matt, or did I miss it?
Yeah, no, and it's related to that, which is I guess that maybe I should have asked this one first, but the question was really who stores the health passport? So is this something that the patient, in theory, would be carrying around with them, or should the doctor be keeping this, or both?
I think it's for anybody really that can utilize the information. And so, in terms of like at the St. Joseph's Hospital, for instance, they are the individuals, they are the people that actually give the information, that give the health passport to individuals, and also keep the information for themselves as well. So they sort of said it's like, when they have frequent flyers, when there's people that come in on a regular basis, they already have this information on the file and they keep it on the file. So I think anybody really that can benefit from having the information, I don't think it really matters who is has copies, as long as all relevant folks that can have the information can have that. So, you know, you might have an individual that shares it with their general practitioner. You might have an individual that shares a copy with when they have a clinic audiology appointment and things of that nature. You know, so it's sort of that's why it was sort of designed not to be too overwhelming to have all this information, but be able to share it quite easily with whoever really can benefit from the information.
Oh, great, thank you, Liz. I have one other question here. Well, you know, as I guess most people get older, their circle of support tends to get a little bit smaller, and this question really is about older adults with intellectual and developmental disabilities, and wondering if there are programs out there that are inclusive for older adults with IDDD and adults without IDDD, if you're familiar with any of those. Either one of you, actually, if you've got any ideas on this one.
I think there's a bit of both in terms of some programs, some agencies are having more sort of aligning what the individuals who are getting older in their agencies might need, some information and some extra support. But also, I think in some situations, there's some of the generic aging services that are now reaching out to intellectual developmental disabilities as a population. And throughout the states now, there are what we call aging and disability resource centers that some states have, and it's basically a combination of the agencies, administrations on aging in the particular states that have identified some of the local area agencies on aging, and to become not just an aging resource center, but aging and disability resource center. So I think we are seeing a definite shift of the realization of the aging population and the population with individuals with disabilities have some similar needs that can be helped by sort of merging the two systems rather than being served by disparate systems. And we certainly are seeing that is going to be, I think, a move and a thrust forward in the future that we will see.
Great, thank you. Well, I think that's about all the time we've got for questions. Let me just go over a couple of logistics here. For people who would like to obtain their CME certificate, you can go to the link on the screen. That is bity.com/PEDD2012. From there, you sign in and register if you haven't already registered. Most people have, but if you haven't, just make sure that you check your spam folder just in case you haven't received the confirmation email. And if you have any questions or any issues, you can just go to aadmd.org and hit the contact button, and one of us will help you through that process. Once you're there, all you have to do is complete a survey and then take the quiz. Passing score, as always, is 7 out of 10. And once you've gone through that, you can have a certificate for your participation in this course. I would like to thank all of you for attending tonight's installment of the Physician Education Developmental Disabilities webinar series. And I would especially like to thank Dr. Akamoto and Dr. Perkins for their presentation this evening and the tools that they've shared with us. Please remember, if you want to get your certificate, just go to the website that I talked about. So please join us next week, Tuesday at 6 p.m. Eastern, when we will have the first of a two-part presentation on assembling accurate clinical information. I hope you'll join us, and thank you from all of us at the AADMD. Have a good night.